So I think one of the most important aspects of our care still remains sepsis. Since 2000, when the original early goal-directed therapy trials came out, Dr. Rivers studied the mortality was 40 to 50% for severe sepsis and septic shock. Today in the United States, it's still on average about 28% in the United States. So it remains our #1 cause of mortality of our critically ill patients. While there's still ambiguity on how you define who's in sepsis, it's pretty clear on what you need to do with the patients in sepsis. I think the three studies, the PROMISE, the PROCESS, and ARISE, the trio of studies as they're often referred to now, really demonstrated the importance of that early goal-directed, or that early resuscitation. The question remains after that, once you've done that initial resuscitation, then the practice becomes a little less evidence-based in terms of what's your goal, how much fluid do you give. But I think what those documents say to us is you have to have in place then that ability to identify those patients, to get the appropriate antibiotics and get the fluids in. Those are things we know from research make a difference for those patients. So the big question of the day is how to differentiate using SIRS criteria and qSOFA. And I think that if you now look at the SIRS 3 papers, which are the papers that came out and introduced and said, let's redefine how we define sepsis and how we identify patients in sepsis. They started with a pathophysiologic, what causes sepsis. The problem with the systemic inflammatory response syndrome is that it happens in anywhere from 70 to 90% of all of our ICU patients, but that doesn't mean that they're in sepsis or septic shock. The qSOFA score, on the other hand, is not intended to be diagnostic of sepsis. It is intended to say there's end organ dysfunction going on. The 3 criteria based on research and analysis of a large database said change in mental status, any change in mental status, tachypnea, so respiratory rate greater than 22, systolic blood pressure less than 100. All should be then cues to you as a clinician that there's some end organ dysfunction going on that you need to then explore the cause. And if that's a patient who has an indication of infection or a risk of infection, that should drive you then into that further analysis, and the recommendation is you use the SOFA score, and the SOFA score is a measure, a more in-depth measure of end organ dysfunction. I think that in this day and age, we as clinicians have to be smart consumers of evidence. These guidelines come out. We have nursing representation on them, but they're not always going to speak to all the aspects. And this is where then you'd say, what are those guidelines? How do they apply? How do they apply to me? You have to be aware of what's in those guidelines, understand how they came about, how are we going to apply them, and then use them as your basis to go back and have a conversation in your setting. How are we going to apply these? How are we going to move forward? And then most importantly, how do we know we're making a difference for our patients? You have to ask that on everything you do.